the only way to start your day.
The people of Lesotho are called the Basotho, right? Yes. If you want to enjoy snow, don't get outside this continent. Just go to Lesotho. Why? Because it's a country that is on the highest elevation across the world, 1,000 meters above sea level. They have the Basotho blanket, would make sense because it's a cold country. But they also export water to South Africa because it is considered to be the water tower of South Africa. Now, let's go to the proverb. A person's character is their greatest resource, treasure, or character. How would you interpret it? Doctor, how would you interpret it?
Yeah, I think character is who we are, whether there are people around us or not. Yeah, and I think that a human being stripped of all the material gains and all the titles just comes back to who you are. And long after you're gone, what remains is who you are, not just to yourself, but to people around you. Yeah. So sometimes even in our practice as medicine, I keep on telling the doctors that patients don't care how much you know. They don't know how much you care. You know, that's character. Yeah, who you are to people. And people remember much more how you make them feel than what even you tell to them. And that's his character, how you treat those who can do nothing to you. So everybody must guard it with all that they have.
Yeah, the skunk is well known for the publicity it gives itself.
Wow.
Where?
That's how you interpret it.
Odiambo.
You can't use a proverb to explain a proverb.
It's very possible in oral literature.
You know, it's interesting.
That's characterization of character.
That's the characterization of character.
Yeah, you know, when you talk about skunk, when you're carrying it out here, well interpreted.
Miskellah is speaking French.
Someone once said, let's give somebody
their skunk.
Somebody said, it's Dennis's friend. Okay, there are two Dennises here. That's to be very clear what we're talking about.
So who owns the skunk? But, okay.
The skunk owner.
Expertise is great.
Well, let's start with that question then. Dr. Miskellah, should health be under the national government? Let's talk about that, because we're also going to be talking about some things that we are seeing in the health sector, and we're really, really worried about. Of course, high on that number here is that we're looking at fake drugs, fake Viagra. Many people will be worried about that. Okay. Fake HIV tests. Even worse, fake ARV tests,
fake
dialysis, fake condoms.
Yeah.
I mean, for goodness sake.
The fake condoms back.
Fake dialysis. Dialysis, by the time you need to go get dialysis, your system is already falling apart. Yeah. So what exactly is happening if the levels of creatinine, for example, continue to rise and that flushing doesn't work? And just last week, a woman gave birth outside hospital because they said, well, we can't offer you services because of whatever. We continue to see the disease burden rising. And so we're asking the question. And then apart from that, the brick and mortar of the health system for the last, many days has had a glitch, which I said, if it's 2-3 days, it's not a glitch anymore. It's a breakdown. All of these things are happening at the same time. Is it time that health was centralized?
Thank you so much. Sometimes matters healthcare really break my heart, because healthcare world is really personal, and you fall sick as a person, and the family and people around you handle you and nurse you and experience the pain at a personal level, and we want to make it very private. We are all potential patients, because as long as you're alive, you're going to die someday. If you're lucky, you can die in your sleep without being sick, but most survive without fall sick or be in a road accident or an accident of some sort. The courage of fire, that courage in Elijah are long gone. Yeah. So we must then ask ourselves that when that time comes that you need that care, whether to recover from or your final care as you go, is the system responsive enough? And I believe that healthcare should have never been devolved in the first place. Or that we live in a country where politics takes precedence over everything. And every time we question the wisdom of why healthcare was devolved, we are told that the teachers fought. Their union fought for them not to be devolved. Where were the doctors? Because the KMA was just talking about when does life begin and whether abortion is a right or not. And it's true that doctors were just trying to speak about science in TV shows. I was young and I could watch it. Yeah. But the teachers were fighting. So then it breaks my heart that so the doctors and the unions which didn't exist then didn't fight for this. Nobody saw it fit to fight for it. Yet even those who are making the law knew that they also fall sick. Yeah. Then we go ahead and make this huge mistake of not just devolving it, but devolving it en masse, because healthcare is over 90% devolved. And I remember when President Uhuru then tried to tell the governors to wait, we devolved it in bits so that we don't have to give them the whole thing to handle suddenly. The COG chair, Isaac Ruto for Bomet, was like, no, Uhuru, you are fighting devolution, give it to us. And Uhuru, being the nonchalant guy, was just that, chukweni basi. So healthcare was then devolved without even costing the function. I laughed the other day when I saw Governor for Kiambu finally saying that these costs that are devolved were never costed enough to know that how much is healthcare, how much you need to send us. Because MOH cannot keep 176 billion annually, which is still higher than even the money that the county spent on healthcare nationally, when healthcare is 90% devolved. So they were told, wait, let's cost this thing before you take it, or let us devolve it per county. They refused. They were told, let's devolve level 1 and 2 community and dispensaries, we see what you do, then you can add you more functions. They refused. They said, give it to us all. And the long run, who ended up carrying the burden? The poor Mwananchi, who this morning wakes up wondering whether they have to go to work or to go to KNH and queue the whole day to seek care.
Which, by the way, at KNH this morning, we are being told that what you would not normally pay for certain things have been increased. Sometimes almost 3 times the amount. Colonoscopy that used to be 9,800 is now 25,000. Used to be 11,600 to get, and a biopsy is now 27,000. An endoscopy was 6,500, is now 20,000. An endoscopy plus a biopsy used to be 9,000, is now 22,000. An ultrasound scan at KNH was 1,800, it's now 4,800. Consultation fee has risen by 400 shillings.
You know, and that's the tragedy of our country. That's the choice between you living and dying. Just about how much you have or where you land in when you fall sick. Yeah? Yet it should not be like that. Healthcare, and the law talks about being that you should get the highest attainable healthcare. Afya, bora sio bora afya. So then you see families are being forced to do what? They're being forced to sell that cow that they're milking to seek this care that they need. And then mommy dies still after selling the cow, or they have to treat her, then the children are left orphaned without that cow to milk. They have to sell that land that they till to get the care that they serve. The people don't make it or heals it, that land is gone. What? So we must then ask ourselves then that what gives in? And I'm so happy that for the first time in recent times, Kenyans have brought healthcare at the core of their conversations politically. So that the politicians know that healthcare has a value political, that you can go home if you run down healthcare.
Well, Dr. I first want to distance myself from the figures, because if you talk the figures, the budgetary allocation, I mean, you go berserk. You become discombobulated. That's the word of the day.
What does it mean?
You just
confused, like
break it down.
Flabbergasted, if that makes it easier.
Yes.
But I would want to focus on the need for provision and accessibility of quality healthcare. We pride ourselves in wanting to do the last mile connection of electricity off-road because we want people to move freely. But we don't pride ourselves in wanting to establish an infrastructure of health, as you rightly put it, that is quality and accessible to each and every Kenyan, regardless of where you are in this country. In my opinion, that is what the Constitution of 2010 sought to provide to all Kenyans. That wherever you may be, there will be a service center you can walk into. Not even drive, but walk into, because it's supposed to be that close to your vicinity. Whether it's a dispensary, a level 1, level 2, and then, the referral system was established. But today, you realize there is a lot of, brick and mortar construction. You hear of governors saying, I've put up 10 level 2 hospitals, 3 hospitals in my county, or 4 or 5. But when you look at the existing facilities today, pick any level 5 hospital in this county, and you walk in, look at the personnel, the instruments that are, the equipment that are required, they are very wanting. We are losing lives every day. So before we talk about the budgetary allocation, which we will, is there a need, because you said health should not have been devolved, but is there a need to get the service to Kenyans, closer to them? And the only stream for now that we have, the constitutional stream we have, is devolution. Is there a need to do that? And if so, is it correct to say that devolution is not bad? It is the people who are in office who are neglecting their duties. What do you think?
No, there's a difference in devolving the idea,
right,
and devolving the infrastructure. I think the devolution we had in mind was not about buildings, because buildings, even President Ruto still opens hospitals in KU and E10. Yeah, in the UHC there are certain pillars that give the universal health care. One of them is the infrastructure that we put in place, and I can assure you that right now we haven't passed the WHO GDP population ratio on buildings, facilities. For obvious reasons that there are kickbacks in constructing them. And the companies that are around it. You see, every governor comes there to construct a hospital. Because as they are constructing the health center, people want to hotel in the nearby market. You get that? That's one. Yes, the infrastructure. Two is the pharmacy and the technology around it. The drugs and the ICT, still pretty well. They still drugs, people are doing good tender business, we have had the managed equipment scheme and all these schemes that brings money.
Albeit fake drugs.
Yes. Then next, you have to have the technology or the ICT to keep the data and records and all that, just database decision making. Then you have to do the HR, the human resource, the people who work inside there. Which side do we have the biggest challenge? And I'll come back to that from the union point of view. But the numbers are low for obvious reasons that you cannot take his salary. You know? So that they don't really like much about it. Then you have to finance all these things. So that the debate comes about, is it tax-based, in the budgeting, do we do the social health insurance scheme, private insurance, do we take grants from donors and all that? But WHO then adds an overarching pillar of these 4 pillars called leadership and governance. And that's where we have fallen short of glory. That in deciding to devolve healthcare, we did not care about, can we run healthcare 48 different ways? That we have 47 governors doing their own crazy thing. Then we have national government doing their own stuff. Then you have private sector also receiving almost 60% of the population doing their own stuff, charging their own things. So you have all this madness in the country that there's nobody who can take charge. When the minister tries to take charge, governor says, no, we are independent, you can't supervise us. Every governor says that, for me, my priority this time around is mother and child. You need to focus on. In 5 years, he's gone home. Somebody else comes that, no, for mine, me, I want to focus on community health promotion.
So there is no continuum of care.
Yeah, it's just madness.
Jacom, with the aforementioned 5 pillars, where are the gaps? Because the moment we start messing around with service provision in the healthcare, we are talking about saving a life, preventing illnesses, and just safeguarding life in the essence of it, whether it's from the conception, from birth, or whatever phase of life. But where are the gaps?
The gaps are glaring, especially from the experiment that devolution, especially with regards to health, is. And I think it is time to stop the experiment. We've experimented for a long time with the health of the people. It's in this country where we are having questions of affordability of health being a real issue that we're discussing, whereas health is a right, which means you get sick, or even before you get sick, you need to walk into a hospital and get treated without being asked for a cent. I've spoken here before about the infrastructure of SHA, which should not be as it is. It should have shifted into something else, and which I've always said that we should have living high-risk consumables, and let those high-risk consumables fund SHA, so that as we buy, because a free market, let that free market sustain itself, okay? Now that's one. Two, we have the problem of the systems. And how I look at it is this way. I strongly believe that results come from a system. They don't come from individuals. Now, when you're talking about an established republic like Kenya, Kenya has a system that works, or that should work. And that system, if it doesn't work because we are a democracy which keeps on experimenting with laws and trying to see what works and what doesn't work, then it's time to correct that system in its entirety. And that system looks like this. The biggest challenge that Dr. Miskellah here will tell us with health now is the question of human resource. If you walk across these 47 counties, And even on, when I got the poster yesterday, I shared it on my Facebook page and asked them, what do you think? Should it be reverted back to the national government? And a chair of health in one of these counties has told me, there's public comment, has told me, I am the chair of the health committee in the assembly, and I want this thing reverted to the national government. Counties cannot manage it. Okay? From my standpoint, and that is as the CEO of Chronic Disease Society of Africa, I look at it this way, that there are bits of health which can be handled by the county, but there are bits which cannot be handled by the county because of these following reasons. One, we have the question of political goodwill. We have the question of patronage at the counties. These doctors are people who are equally learned, just as we journalists are very learned, of course. But the question that happens there is that doctors are treated, and generally the healthcare workers are treated political patronage. You have to earn the goodwill of a governor and his minions. And most of the times, these minions do not understand what health is, because 6 to 7% of the CECs who are chaperoning health in this country do not understand what pharmaceutical policies, for example, are. They're just seated there, appointed to oversee. You're overseeing something you don't understand. One, okay? Two, as he's saying, chief officers in most of these counties, some of them are doing very well, do not also understand why they are there. Because they're there to politic, they're not there to lead. And the question of health is the question of governance and leadership. Because once we leave it to patronage, then standards are put below. Once we leave it to 48 different employers, these healthcare practitioners are being demeaned heavily. So before we speak about anything else in the gaps, the first gap that must be addressed is the formation of a National Health Commission, which I know he has championed for before. And it's time that all healthcare practitioners, all of them, unite in one voice and talk about the establishment of a National Healthcare Commission that looks into their welfare, that looks into their earnings, that looks into their dignity. Because you find, for example, a nurse, is trained to specialize in mental health care.
Yes.
But then you find them redeployed at a county to a pediatric section, whereas this nurse would be effective at a mental health care section. What are we doing? We're having misplaced what?
So what would the formation of that commission achieve? Because from what you're citing, we have a structure on how our healthcare system should work. We have the software. We know how, the operationalization of it. But then you also have the humans. And I think it is the human capital in this aspect that is failing us. Because even if we form a commission, and then we have Dennis becoming the governor of that county, and then the appointment or the chief officer health is based on what you're saying, patronage and political endearment, you're still going to have the same problem. So, in a manner of speaking, is the devolution aspect by itself the problem, or is it the people that we have entrusted, beginning from the CS health all the way down or all the way up, depending on how you look at that pyramid?
You know, something interesting, I would not want to look at personalities.
Right.
For one reason, that personalities often change. All of us in this room are different in our own ways, and leadership, as we see it, is different. I look at systems, okay? And as long as we don't have a system that is productive, then we are expecting a result. It's just like saying, development is by empowerment. Empowerment is by Harambe. It's stupid. Where a CS carries 10 million to Harambe and says this is empowerment. That is stupid, because that's not a system. It can't create people. Systems create people. Okay? Now, if you come back to this very question, health as a question can be tied into 3 or 4 sections, in my view. One, preventive health can be handed over to the county. They have the CHPs, they have the CHVs.
Yep.
This country, and Dr. Miskellah knows this, we wait for the patient to show up, and then we start talking about health at the time that the patient shows up for diagnosis or for screening. What are we doing? By the time the patient is showing up, already something is broken. Okay? One thing that we should focus on, just like Cuba is doing, focus on preventive health. If we focus on preventive health, we're going to cut down the cost of treatment by more than 50% of our budget that we're talking about. And that focus on preventive healthcare should be given to the what? To the counties. As CDSA, what do? is we do a lot of public education on different issues. Like just the other day, we were doing something about respiratory illnesses in Siaya. And we find out that if a lot of effort was placed in preventive health and handed over to the county specifically to continue it, give them some little money, let them do education. Education is easier than treatment, because treatment, we need standardization.
Yep.
Health is a national security question, just like education for me, just like transport for me. It is in this country where we're having a free market, where transport is in the private hands, okay? Where health is a business. Where education, we have private schools where some children are dying in those private schools because of lack of standardization. Now, unless we standardize and agree that preventive to party counties, but on the issues of treatment and the issues of healthcare professionals handling, let's leave it to the national government. The issue of infrastructure, as you said, counties are messing a big time. There are some of them which are doing very well. You've seen like Kakamega has put on a level 6 facility, which of course they're handing over to the national government. Beautiful. And many more level 6, level 5s, level 4s, which they've built. But the question is, if you go to some counties, can I surprise you, for example? Siaya County, this is year what of devolution? Year 13?
14.
Year 14. There's no renal section. Renal unit. There's no ICU.
In Siaya.
In Siaya. I was shocked.
The whole of the county.
The whole of the country.
But I saw they launched a morgue the other day.
I mean,
I was shocked.
guys, it's Daktari. Daktari.
Yeah, it was everywhere.
Yeah.
Yes.
Daktari, when you look at healthcare, one of the key things that continues to be discussed is the resources that go into it. So national government would read their budget policy and how much they're putting into health. But if you look at, even when it comes to the equalization, what goes to the counties, will give you 400 billion shillings for you to decide how much you will put where. There has never been a conversation on, we are giving you 400 billion, but this amount should go into healthcare because it is important for healthcare to be a win in the counties. We look at conversations, even the construction of level 6. I wonder why a county would be putting up a level 6 hospital, which in its entirety, that's the work of the national government. There is issues to do with collaboration. But one asks the question, if the counties were using these funds to enable the facilities, the resources that they do handle, then that would help in enriching healthcare in these counties. Is UHC a reality in this country, or are we trying to achieve it, or is it just another political gimmick for us to say there is something to talk about?
You know, my namesake, as I sit here, I really get enraged. I really get angry because everybody knows the problem. The governors know the problem. The president knows the problem. The minister, we talk about all these things with them in the offices.
Yeah.
They know where the problem is. They know where the failure has been. Whatever is lacking is just people are selfish. Because governors want to have this power that is just imaginary. That I want to be able to hire and fire doctors. How does it help you? The only thing I know it helps them with is that I know for a fact that to be employed as a doctor in this country, you have to give a bribe of 1 million shillings.
What?
To be employed in this country. Those county public service boards demand 1 million shillings for bribes. That's if you're told do internship.
That is a
save
standard.
for that kind of money.
That is a standard, Doctor.
Yes, yes.
Okay.
Number one. Number two is about your second name. If you are a Luo and you go apply for a job in an Alu area, or number no. Enter out Africa.
Continue.
For real, is that
Go
what's
to your
going on?
account. Yes, that's what happened.
Miskellah, that's what's going on right now.
Come on, I will not be lying. You get that? You're being told, do that. But more importantly, is that in those payrolls, there are ghosts. Somebody tells you that you have 50 consultants, but only 10 are on the ground. 20 are just governors, campaigners, advisors on that payroll because doctors are the highest, so they have to sneak them into it. You get that? That's the tragedy of this country. And the issue around finances is only that while we acknowledge that we live in a country where resources is limited, but there's enough for our needs, but not enough for our greed. Yeah? What we now have is madness. Because if you say that you don't have enough money to employ doctors, but then you have enough money to build a facility that is just going to be empty. A doctor as Miskellah, we do even medical camps under trees. I will still treat. But an empty building, we don't treat nobody. The contractor will go smiling and the governor will kick back or her kickback and they go away, do the other things. Yeah? So we have to go slow on this madness of building. Talk about Kakamega, beautiful word. Do you know before national government took it over, it had swallowed 10 billion white elephant?
Yes.
10 billion would construct and equip a hospital to completion. You get that? So, kuna mchezo ya town. You talk about CHPs. Folks were told that get CHPs to help run private healthcare. Yes. Who do you go? Get your local goods and campaigners in the villages and give them those bags and tell them you are a CHP. They don't even know you how to take a blood pressure machine. But more importantly, that after you have told me I have diabetes or hypertension,
then what?
Then what? Yeah. You just caused me to become anxious. I land in the hospital. There's no doctor, there's no drug, there's no lab to do nothing. So that's not good enough. On matters of Health Commission and how we could approach this healthcare debate, if we were honest. And I challenged you, yesterday we were with the Honorable Duale, and I told him that, go tell the president that if he truly cares about Kenyans and cares about UHC, him and all the presidential aspirants who intend to vie must commit to Kenyans that they must give us a referendum in the next dispensation. That let Kenyans decide. We don't even want them to have an opinion on it. Governors or politicians. Before Raila died in BBI 2, BBI 1 had the Health Service Commission. The governors went and blackmailed him and told him, if you put HSC, we are not supporting BBI. It had to be pulled off. In President Ruto's manifesto for order, he says that he acknowledges the problem and he promises to be a neutral arbiter on this case. The governors again blackmailed him and he backed off from it. And they put this thing, some moribund, toothless body that cannot even help us with the inter-county transfer. Like today, my mother is sick in Kisumu. If I chose, I want to go live near my mother, I can't transfer from where I work to Kisumu. Or even if I have a spouse in Mombasa and work in Bungoma, we may be as interns in one place and I got a job in another country.
Daktari,
I can never live with my wife together because you can't even transfer within the same country.
Daktari, allow me to ask, because I mean, I don't want to come out as if you're holding brief for the president. One, I think the issue of public health is an issue of internal security. Therefore, if we put politics aside, we must agree that the way we dealt with terror or terrorism, terror attacks, is equally important on how we need to deal on matters health. I don't, in my opinion, and I want to be corrected, I don't believe it is an issue of a governor or a president or a CS. It is an issue of incompetence, in my opinion.
I agree with you.
Because even when we talk of letting the national government or now centralizing the health matters, you also have to look at the facilities that are being run by the national government today. Kenyatta National Hospital, Moi Referral, the Jaramogi Oginga Odinga. You look, I mean, there are about 6 or 8 or 10 facilities which get direct funding every year. Today, in this budgetary allocation, we have about 48 billion going to those facilities. And the just concluded financial year, they received almost a similar amount. But you don't walk to Kenyatta today and realize the impact of those resources. You don't walk to Kenyatta today and realize that the personnel and the welfare of the people working there has been catered for. So the real conversation, in my opinion, is not about one, lack of resources. It's not about lack of personnel, because every day we are graduating people. It is about the people we have in office. What would happen if we agreed that universal health coverage is a basic right that must be? Must. It is not a constitutional crisis we are having. I don't think centralizing it would solve the problem, because you still have maybe the same characters working in those corridors. But we look at not the constitutional issue, but the implementation and holding people accountable. When CS tells you that he knows there is fake medication, it is there today in the dailies. Who takes responsibility? Whom do we hold accountable?
To dispel the myth that the level 6s have failed. Let me tell you, if not for KNH in this city, this city would not just this city. KNH carries such a huge burden that even a mother with cervical cancer in Homa Bay, I meet her in the clinic here in KNH. I've traveled the whole night to come to KNH. KNH is overwhelmed. If not for KNH, this city would crash. People come from Marsabit to KNH. I refer from Embu to KNH. What we should do?
You don't see that as a crisis by itself?
The crisis is because the counties have failed. If you kept, why would a woman who's pregnant come deliver in KNH a level 6 when there could be maternity units in every other sub-county?
Level 2,
yes,
3.
Right. You go to the UK, the NHS system, you don't just walk into King George Hospital. You start to call, they call them surgeries. Yeah, the small facilities before you get there. On the matter around how do we then devolve health in a way that makes sense.
Yes.
Initially, I used to be a huge proponent of the Health Services Commission, where we wanted this centralized body that will handle the HR bit of things, the employment, the promotions, because we have had over 120 strikes in this country from Devolution, and they're basic things, not at the salary. Right now in Isiolo, we are on the 3rd month without a salary. How do you work a doctor 3 months without a salary? In Meru, they are on their 10th year without any promotion. They are on a strike there on week 5. Kericho has also begun a strike also. And we are having so many of these counties doing strike because of basics. Just promote me. Give me a medical cover. In Isiolo, they have no medical cover. Unakatwa SHA, our remit. Retirement, unakatwa, haipeleki kwa retirement. They can't deduct pay, they don't give care, you can't even file your taxes. You have no medical cover. A doctor just took a loan of 1.5 million the other day to pay her bill. We have in Transnzoia, we have a strike going on. Why? Medical cover. There's a doctor who has a cancer. She can't go surgery because of lack of money. There's one who needs digital transplant. Can't. We have another one with a open heart surgery need. Can't. And these are the realities that doctors have to deal with. Not like doctors, county employees. But doctors have to make the loudest noise because we can see it. So what would I suggest if the governors find it so hard to release the HR function, which they have insisted that they can't let go? And I still know that even when you give them to buy drugs, they won't buy the drugs. I'm very sure about that. So then why don't we then say that healthcare looks like it wasn't what the governors thought? Because for them, they thought that when they see these big hospitals in the city, this big private charging a bill of 5 million shillings, they're like, this money, wow. Well, what about if we say that let's devolve level 1 and 2, where it's community and dispensaries? They have done a good job with the ECDs.
Absolutely. That was the example I was going to give.
Then when we go into the curative, which is the most expensive part of healthcare, then you say that this is now slightly beyond you. Let level 4, 5, 6 national, level 1, 2, 3 county. Get that? Then we tell them that if you invest in preventive care, $1 invested in preventive care saves 9 in curative care. Then we'll start going with the Cuba way. We start reaping the real benefits of the evolution that was, if they're willing to do that. But are they?
Jacob, is healthcare in Cuba publicly funded? Or do they have a model or equivalent of a mongrel we call SHA? Because I think, in my opinion, if we can graduate our healthcare to publicly funded health system, we might be able now to standardize in a manner that now you don't have to labor the numbers for you to get compensation as a facility. But I don't know if you have reference from Cuba or any other country.
I have quite a number of references that I can make. One, we have Thailand, which for me is one of the best universal health coverage formulas in the world. In fact, the best in the world. We have Rwanda. I know it's quite an autocracy, but its health systems are working. Of course, Cuba is one of the most beautiful ones because of their doctor to patient ratio, which is very beautiful. Because in Cuba, I think it's 1 doctor to 1,000 patients, or 10,000, something like that.
Where are we in Kenya today?
Kenya,
roughly
17,000.
17,000 to one healthcare practitioner. Actually, one healthcare practitioner, not even one doctor.
Wow.
And in Kenya, we are graduating about 7,000 healthcare practitioners every year against the demand of 70,000 every year. Okay? Now, set that aside.
Right.
The biggest question that then comes in is this. When we're talking about promoting healthcare at the level that everybody feels it, we first talk about the affordability. We hold medical camps, a lot of them. I can tell you, so many people who show up at the medical camps, they are struggling with one question: affordability. Because even under SHA today, you still have to give something apart from the cover that is given. And that's a concern. If you go the Thailand way, and that's what we've advocated for, and just allow me to say it because the moment we start getting tired is the moment they start listening, that we must levy high-risk consumables so that high-risk consumables fund our healthcare. I don't know, Miskellah must have done the calculation on how much we need to fund our healthcare end to end. If we, for example, levy just a shilling on bread per day, bread is a high-risk consumable. The public may not want to have that discussion, but it's a necessary discussion. Alcohol is high-risk consumable. Processed sugar is high-risk consumable. Tobacco. And so many more. Soda. In fact, soda is a useless thing. Soda is one of the most useless things that people take. You take a lot of soda, it does not add any nutrition to your body. It only promotes insulin resistance.
That's nice.
In your body. It tastes nice, yeah? But it is affecting you badly. Today, 60% of chronic kidney diseases, I can tell you, is a result of mismanaged diabetes. Okay?
Sugars, yes.
Yes. Mismanaged diabetes treatment. And it accelerates further and leaves you at cancers, leaves you at, I don't know, they call it diabetes foot or something. There's so much that comes with it. Now, the moment we're not talking about affordability, we are not starting to talk. And counties cannot handle the question of affordability.
What does that mean?
They
Counties
can't
cannot
handle financing of health in terms of generating money that can assure every citizen and resident of the county that you can walk into a hospital and get treated. Counties cannot do that function.
Can't or won't?
Cannot, will not.
In fact, the worst part of it, I sorry to interrupt you,
Yes,
is that
sir.
they're not just inputting money.
Yeah.
It's scandalous what the countries are now doing. Counties are now dipping into the... You see, the SHA came and said that they reimburse facilities.
Yes.
Yeah.
Money is sent to bank account to the... Now counties, when they hear that SHA is reimbursed, the governor comes for his cut, and they come for it in cash.
Cut of what?
Whatever SHA given.
How does he have
There
a
was
cut?
scandal the other day in one of the South of the country. Well, we were lacking drugs, labs were shutting down, child delayed to reimburse. Then the money came like this. The first person who came for this share was the governor. Came akachukua yake. Mnaambiwa ile imebaki mjipange nayo. It's madness.
But that's a criminality.
It is.
Yes,
How
it's
do you
madness.
have a cut?
Leadership and governance issues.
How do you have a cut of money that's supposed to go towards paying facilities for services that have been rendered to patients in the
Because
country?
the challenge in this country is we have a question of eating.
Yes.
The eating question is a big problem in this county. In this country, there are several counties which, of course, are doing exemplary well in terms of medical whatever. They're doing exemplary well. As much as we would like even to bash, let me just rebut on this. We'd like even to bash Kakamega County for that 10 billion thing. I would go again to the specific leader who was there then, who was Oparanya, and I'm not afraid to say it, that when he invested that amount of money into that level 6, he was hoodwinking the Kakamega residents. Because why should you start building a hospital which is not going to finish? Now, when the new governor comes in, he finds, there are so many pending bills here. I cannot even finish constructing this thing. So what do? The governor now, Barasa, hands it over to the national government. Says, you know what? Anyway, level 6 is under the national government. Chukweni hii kitu, mumalize. Okay?
Yeah.
So yes, there's that, which is bad. The biggest question is the extraction mentality that we're having as politicians in this country. We wonder when we go to counties, we don't go there to lead those people. Because look, it is sensible, that if you look at yourself, in 40 years from today, God willing, all of us remain alive, and you are retired, and you've gone back home, and you have a heart attack, okay? I know it takes between 5 to 7 minutes for you to be saved. Today, if I go to Kabondo, where I come from, okay, and I suffer a heart attack, I'm slim, yes, but I can have a heart attack. There is no ambulance which will respond in 5 to 7 minutes. Because those ambulances are not there. But how much is an ambulance? Equipping an ambulance?
But
It's so cheap.
Yeah.
When
It's
you
so
are about
cheap.
40 years,
Yeah.
when even right now, if you think you're a middle class, you're a governor, you don't care about public health care,
Yeah.
you take your family to Masai Mara to see the migration, you get a road accident, will you be saved where you'll go to? Or you go snake bite you and doing
they are
in the
lifted.
village?
But they
Can you
are-
be saved?
But
You
they are
won't.
lifted. They are lifted to...
Yes, I saw the governor.
challenge. It's extraction mentality.
A governor for Meru, the former governor who said that they want an airport in Meru to be able to lift the money up because emergencies.
So
It's terrible.
would we be in order then to argue that the issue is leadership?
It
That
is
the
national
issue
governance.
is
Largely. Now, when you talk
because-
about leadership,
right.
let's go to the question. When you talk about leadership, what creates leaders? Or what is it about leadership? If you look at political systems, you'll understand one thing, that when countries are small, they're made by people. I want to give an example of Rwanda. It's a country that I like giving an example of, but politically it's incorrect. But I'll just give it nonetheless. Rwanda is a very small country. When it was in a mess in 1994, in fact from 1894, because the genocide is a 100-year issue, from 1894 to 1994, there was a mess, there was no leader.
Right.
They're just people, tribal chiefs, etc., masquerading as presidents and things like that. But when Paul Kagame took over the reins of power there, he made Rwanda look like a country. He made some systems functional there. In fact, the democracy in Rwanda is far much better than ours. I can tell you that I've been there. Far much better. The only question is that the presidency is not touched. But hapa chini, everything is touched.
The systems are working.
Yes, because the country is still small. Now, when countries become big, they make people. our country started from a wrong foundation. And I'm not afraid to say it. Jomo Kenyatta, the first president of this country, messed us up. His mentality was extractionist. He extracted to a level that anybody who was coming after him just wanted to do what? To also extract. Now, 60 years later, the country is now big. Our democracy is mature. Tunapigwa mfano. You go to Tanzania, they're talking about, look at the judicial service of Kenya. Look at the health whatever of Kenya. Can we make it better? We are stagnating somewhere there. The reason why we are stagnating is because we have allowed politicians to take charge of our systems. We must institutionalize, and that's why I may always say, healthcare needs a round table, where even in that health service commission that I'm talking about, let us have COG represented there. Let us have the national government represented there. Let us have the public represented there. Let's have people who are fighting for chronic illnesses like us represented there.
Can I ask how that's supposed to happen? Because I'm a bit perturbed, actually a lot perturbed, by what Dr. Miskellah is saying here. That if money is released from the exchequer, because this is exchequer release of money to counties, or rather to medical facilities through SHA, or whatever the case may be, Ministry of Health, for money that's owed to them, back payment for medical services that were offered to patients, right? A governor comes to take their cut. I don't understand how it becomes their cut, but anyway, comes to take their cut of this money for whatever they felt. Maybe they breathed in a meeting somewhere, so they imagine that some of this money should go to them. But these are the same people that you're asking to be on a round table to have a conversation about how you need to make health better. I'm a proponent for, if you succeeded in contributing to the problem, you cannot be part of the solution.
The challenge, is that you have a very brilliant thought. But the challenge in this country as well is that we have a problem with the base, which is the voter. Today, you and I and Miskellah and my friend here and Dennis here, we know that this is how things should be. But when it comes to voting, that mwananchi at home does not recognize that, hey, this fellow has a question with ethics. Don't vote him in. They'll vote that thief in, because Africa, today, Africa, not just Kenya, has two publics. We have the primordial public and the post-colonial public. The primordial public is the one that believes that stealing is bravery. They believe that if you're a thief who steals and robs people and brings to us, then that is beautiful. So, as much as we'd want to say, these people should not sit at the table. Unfortunately, the system down there is producing these people. Because you today try to contest in Nairobi, they'll tell you no.
Yeah.
Dr. I'm asking the question, yeah? When you look at implementation of healthcare in a country, it is a policy issue. In Kenya today, as we speak, there is a policy position where you'd say this is the national government policy position. When it comes to the counties, we have 47 different policy decisions that handle healthcare on that level. And one asks the question then, as a country today, what is our healthcare policy that is supposed to take care of wananchi? Because one would say it would be easy if we have two policy positions where we say we know national government handles this, and we have another unifying policy that handles issues at the counties level 1, 2, and 3. But here we have 47 different policies, 47 different decisions, even on matters to do with human resource, on preventative CHPs. Can we operate in saying we are offering healthcare to wananchi with a confused system, confused policy positions that does not offer solutions that we talk about today?
Yeah, in Schedule 4 of the Constitution, it talks about that policy is national government function, just like labor standards. Yeah, but many a times, because of gatekeeping and just selfishness, just not caring about the wananchi, the people then who are bestowed with the responsibility at the county level, they don't look at this opportunity to serve from point that how can we help our people? Yeah. Today, if the PS of health were to call chief officers who are his equals
in
the
counties
together, or just do memos to them or guidance, or they not come. They say we are not involved. The other day, interns were being sent to the counties. They're going to 6,000 new workers being sent to help in the counties. None of them turned up even in MOH to talk about, to receive them. During COVID times, every county was given almost 400 million to build ICUs and facilities. Tell me why you still don't have ICUs in county like Siaya, in Isiolo, if people are given money for this, and they didn't do it. Because they know that he does headache, any headache, yeah? Headache, yeah,
Yeah.
Onela. But I like what has become of this country lately. That finally the young people and even the older folks also are finally connecting their problems and their leadership. People are finally saying that we don't have this because this is wrong. In fact, for me, if the Gen Zs wanted to change this country, forget about reaching State House Nairobi, it's just too complex. You'd have started by chasing those governors in the counties because they're responsible for some of the most direct troubles you have. People think that building a road or launching a water project is the most important thing in their lives. But people repeat that beautiful road you are building, that dual carriage to Western Kenya, will be used to carry dead people who come to die here in Nairobi seeking care. Giving 700 billion for education is perfect. But I'd rather have an ignorant man live up to 80 than a professor die at 40. A sick policeman won't go to work, a sick doctor won't go to work, neither will be a sick student. So if we didn't learn from COVID that healthcare is the center of it all, and until we put our mouths and our monies where all this is happening at.
Doc, let me ask a question. Today, if, say, Cabinet Secretary calls a CEC in Mombasa, say in maternal health, Mombasa, would the response be the same with him calling another CEC, say, in Turkana? It will.
You know why? At a good example, the UHC staff. The UHC staff were hired when the monies came from a donor, say that we want to support you in fighting COVID. But this money, if we send you the counties, most likely they'll never use it to hire. Or they'll hire just their local goons and claim they're healthcare workers. So MOH decided to employ centrally, then send these folks to the counties to help. Part of the deal that was like we support like for 2-3 years, then you on your side absorb them and pay them. MOH then goes ahead and allocates 8 billion for people to be absorbed and to be paid on PNP, permanent and pensionable. But the government then said that no, you can't give us workers, you can't tell us what to do. So right now, the young people who save this country are not yet converted, not because there's no money, not because MOH has not given the direction, and the president himself gave the direction. Governor said, no, you give us the money, we'll decide who we want to employ, because we want to do other shenanigans around it. That is the kind of nonsense that is going on. And that's why we are stuck with it.
And also perhaps, Daktari, it might be nonsensical for the governors to claim that, but also they could be landing on the constitutional right that the health is devolved. So I think also the national government should not have the luxury of picking and choosing when to implement devolution. If a function is devolved, resources should follow.
However, if a function is devolved, you need to also make sure it's just like a communication. I can communicate to you, but true communication is when there's a feedback.
Yes.
So when I say that it's devolved, we must actually have to see the thing live out. But in this case, I believe that people are riding on this devolution thing for their own shenanigans. If we actually see that form follows function and that money actually follows this function, then we would actually see healthcare being a thing where it is operationalized around the country. People wouldn't be dying from things like malaria. People wouldn't be dying from things like there is no ambulance, there's no IC. I mean, for God's sake, 20 billion shillings has been given to a county, there's no ICU. That's the basic thing that we're talking about here. So maybe my final question would be... Exactly. So my final question would be: would it make a difference if perhaps the law on devolution should not change? Where the law should change, is a question, is the insistence that everybody, as Dennis often asks for, let everybody use the public health system from top to bottom to in the middle. You will ensure that then it functions. Does that make sense?
Yeah, I think that it is dishonest as a parent that in the morning you make a breakfast for your kids, tell them kunyendo chai hakuna mkate, then wewe on your way unanunua mkate ukikula ukienda kwa ofisi. Or you cook, you run a hotel here, but when you're going for your meal you buy food from the next hotel. That's what they're doing. You run health in your county. When you fall sick, you tell us how God saved you when you came to Nairobi Hospital, whichever hospital you went to. Or somebody whose nose was broken in Bomet and went to South Africa. How do you run health and you don't protect yourself? Yeah. My plea to wananchi is that please, in this coming election, make healthcare your agenda. It's beautiful, all these are stories you're being told. But make healthcare. You can only live long to see that Singapore we hear about if you're alive. Then we can't see Singapore. So, from the MCA, ask them what role have they played or what role do they plan to play on oversighting and budgeting for healthcare. To that governor, to the MP. Yeah, some of these laws we cry about, share bad, share good, blah, blah, blah. These are laws that can be changed in parliament.
Yes. Which
MP, even those ones in Chilinda, Wananchi, Linda, Kenya, what have they done in changing that law? They can just be talking on TV and on podi and don't bring it to the ground.
To Linda Afia.
Yes, to the governors, to the president. For me, I say that if I were to meet the president, one thing I'll tell him, and anybody who's vying, and we'll look for them as a union, you have to tell us that, are you promising us not to take away the devolution of healthcare, but to give the wananchi a chance in a referendum to choose for themselves whether they want to continue dying like now or they want to live long enough.
And that's where we ended this morning. It has to be an agenda that if you are sick and across board, there's nothing else that you are doing.
Yeah.
And not just sick, but not in your body, but also how you operate.
Yeah.
Dr. Dennis Miskellah as well as Odhiambo Chen, thank you for joining us this morning. This is one conversation that we cannot keep on the back burner. It has to be front and center. Asante sana, both of you, for joining us this morning.
wamesema tuache mchezo mingi.
Wacha mchezo mingi.
Enough of the study.
The latest news from around the world. 94.4 Spice FM. This is the Situation Room. The only way to start